I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hey everyone, and welcome to the July 2017 edition of the PRS Journal Club podcast. My name is Shuja Shafqat, and I'm a PRS resident ambassador from Lehigh Valley. And as always, I'm joined by my co-resident ambassadors, Jordan Frey from NYU and Chad Purnell from Northwestern. Today we have the great honor of having Dr. Noopur Gangopadhyay, craniofacial surgeon and microsurgeon, and assistant professor at Ann and Robert H. Lurie Children's Hospital of Chicago, joining us today. Thank you very much, Dr. Gangopadhyay, for joining us today for this PRS Journal Club podcast. The article we'll be discussing next is the efficacy of perforator flaps in the treatment of chronic osteomyelitis by Drs. Hong, Go, Choi, Kim, and Su from the Asan Medical Center in South Korea. And just as a reminder to everyone, all of this month's articles can be read for free on prsjournal.com, including an archive of all past Journal Club articles. In the introduction, the authors talk about dealing with chronic osteomyelitis, and certainly it can be a challenge, and how the best treatment is debridement of the affected bone and soft tissue that's really preventing the antibiotics from getting to that area, and then adequate reconstruction. And there has been a lot of debate about muscle flaps compared to fasciocutaneous flaps, or even just cutaneous flaps for the treatment of chronic osteomyelitis. And we know that muscle flaps are known to have good blood flow, they translate into good antibiotic delivery, inflow of immune cells and factors, promotion of bony healing. But one of the criticisms of muscle flaps is the difficulty for re-elevation for secondary procedures, including bone grafting. Fasciocutaneous flaps were thought to provide the same advantages with better ability to elevate the flap later on, though the concerns were, what if they don't provide the same benefits that muscle flaps do? So the goal of this authors were to look at perforator flaps in treating their patients with chronic osteomyelitis. So they looked at all patients diagnosed with chronic osteomyelitis over a 14-year period and had an average follow-up of almost 4 years. All of their patients had imaging in the way of X-ray and CTA at the very least. They did an MRI if the X-ray was equivocal for infection or to look at the extent of the infection, and they did a formal angiogram if the CTA was equivocal. They debrided their wounds in single or multiple stages. Bone dead space in localized osteomyelitis was filled with either a muscle portion of a flap, a deepithelialized portion of the flap, or antibiotic beads. And they did note that if the osteomyelitis was diffuse, that external fixation was performed for more stability. They then reconstructed the wounds with ALT, skip, gap, upper medial thigh, and Tdap flaps. For major vessels, they performed their anastomoses end to side, and for branches, perforators, or major vessel stumps, they performed them end to end. Venous anastomoses were done to the vena comitatantes, or the superficial systems. Antibiotics were all given for 4 to 6 weeks, and secondary bone grafting was done on average about 2 months from the initial reconstruction. Their average length of stay was 10 days, and their first assessment of primary remission was made only at 12 months when symptoms, pain-free ambulation, and resolution of the inflammatory markers was achieved. So overall, they had 120 patients that were on average 47 years old, with the majority of osteomyelitis due to trauma. Most of the patients had at least one comorbidity in the way of age greater than 60, diabetes, smoking, or peripheral arterial disease, which is around 20% of their study population. 3/4 of the patients had a bone defect that was either localized or diffuse, which is grade 3 or 4 by the Cerny-Mater scale. Just over half the patients underwent a single-stage debridement, with the average number of debridements prior to reconstruction was about 1.7. Just under half needed external fixation. Over half the patients got an ALT flap with or without vastus lateralis, and they noted that their vastus lateralis was independently pedicled and not a musculocutaneous type flap. They had 5 patients with total flap loss, 10 patients with partial flap loss, 10 patients had recurrent osteomyelitis, and surprisingly 80% of them were after complete flap healing. 90% of the recurrences occurred within 12 months, and their primary remission rate was 92%, with a final remission rate around 98% at 2 years. Only 1 patient required amputation, and as for predictors of recurrence, the only significant factor that they could detect in all the factors they looked at was major vessel compromise, either by injury or peripheral arterial disease, which they noted bumps the recurrence rate of chronic osteo from 5 to over 20%. So in their discussion, the authors discussed 3 major components to reconstruction. First being the bony reconstruction, which can be done by secondary grafting, distraction, or bone flap, which is 2 patients in their series. Second is filling the dead space, and they highly recommended the ALT combined with a vastus lateralis that is independently pedicled, which accomplishes all of the components of what they were looking for. Alternatively, they used deepithelialized flap segments or antibiotic beads with no statistically significant difference between these 3 techniques. Their current protocol uses antibiotic beads for all bone defects, deepithelialized parts of flaps for small soft tissue dead space, and muscle for large soft tissue dead space or functional muscle reconstruction. And their third component is coverage. And their rationale for the perforator flaps is that they're easy to re-elevate and re-inset, more likely to survive if the pedicle is injured on re-elevation. They more readily replace like with like, and that bony continuity can be restored with bone grafts under cutaneous flaps. Also, that skin paddles allow for better monitoring, and perforator to perforator anastomosis can be done to do this in a more minimally invasive technique. In their series, they note that injury or disease of a major vessel leads to 5 times increased rate of recurrence of osteomyelitis. And overall, they conclude that perforator flaps can achieve good remission of chronic osteomyelitis, but they note that if the 3-step principle is followed, the flap providing coverage isn't so important, and that the recurrence was likely related to incomplete debridement or poor vascularity. So overall, I thought this was a really good paper. I think they had an excellent series, and I personally liked how they broke down their approach into the 3 critical parts and how to perform them successfully. I did like how they added the caveat at the end that the resurfacing flap wasn't crucial, and more likely it was other factors that were leading to recurrence. One thing I would have liked to mention is that they note that some of the other studies that looked at this issue had a heterogeneous population, and they also had a pretty wide range of patients in various groups with regards to the grade of chronic osteomyelitis. And while they did look at the need for external fixation as a risk factor for recurrence, they didn't specifically look at the stage of their chronic osteo or the Cerny-Mader stage. I also thought the discussion was interesting and does mention that the study didn't prove that perforator flaps are better, but can provide an alternative that was reliable. So with that, Dr. Gangopadhyay, I would be interested to hear what your take is on this article.
Shuja, thank you so much for your comments. I thought this article was really excellent. The senior author of this article is an incredible microsurgeon and should really be commended for this large series of basically free perforator flaps and perforator to perforator anastomoses, which are challenging. I think in this article, they've really provided an approach essentially to perform limb salvage for patients that would otherwise be poor operative candidates or potentially have to live with potential below knee or even above knee amputations related to prior trauma. So I think the ability to perform microsurgery in this challenging patient population has really improved the quality of life for these patients. I thought their systematic approach and their measured discussion of their results and the indications was very appropriate. I thought it was a really well-written paper.
That's great. I thought that those are good points. What is your personal take on the muscle versus free skin flaps for extremity reconstruction? And is there a population where you might pick one over the other, or does it kind of depend on the overall patient factors in the patient picture?
I think the caveat really at the end of the paper, which I agree with, is that there's really no reason to use a muscle versus a skin flap. At the end of the day, it's really what you're most comfortable with as a surgeon and what the patient factors are. I think they've really extended the application of perforator flaps and have tried to decrease the morbidity associated with harvesting some of the muscle flaps. The nice thing about the perforator flaps that they tended to use is really some of the operative details. So when you're trying to do lower extremity reconstruction, if you can avoid a position change, that certainly will decrease your operative time and make the surgery easier. And so the nice thing about performing below knee reconstruction and harvesting, for the most part, anterolateral thigh flaps or thigh flaps based on the descending branch of the lateral femoral circumflex, is that you tend to not have to change the position of the patient. Whereas if you're harvesting a very large muscle flap, and my go-to is often a latissimus dorsi, you either have an awkward flap harvest or the person preparing your vessels is in a somewhat awkward position. And certainly the morbidity of taking your entire latissimus when you may need that for physical therapy and occupational therapy afterwards with wheelchair training or gait training with crutches can be somewhat challenging. That said, though, if you're more comfortable with the harvest of a large muscle flap such as the rectus abdominis or the latissimus dorsi muscle rather than a skin or adipofascial or fasciocutaneous flap, then you really should use the flap that's going to work the best in your hands. The other nice things about these large muscle flaps is they often have a much larger caliber vessel than the perforator to perforator anastomoses that Dr. Hong has described in this article. And that may sometimes be a better option for you depending on where your vessels are and where the zone of injury is. The interesting thing about this paper is that they often were operating within the zone of injury. And I think one of the tenets we learn as a resident, certainly when we're doing reconstruction of the limbs, is to try to get outside of the zone of injury so that your vessels are as good as possible. But they've actually have taken vessels that have had a hit in several ways, whether it's from the trauma, the fact that a number of these patients were diabetic, a number of these patients were smokers, and a number of these patients had peripheral vascular disease, and really extended the applications of microsurgery. So I think some of the traditional contraindications for microsurgery and trying to get away with a more limited approach, they have gone past. And so I think you can use a muscle flap or a perforator flap, but taking into account some of their considerations, you can really extend the use of microsurgery for those patients that previously wouldn't have been salvageable.
Great. I think those are excellent points. And, they really hit the nail on the head in the discussion and at the end of this paper that muscle flaps are also a good option. But really, at the end of the day, it does kind of depend on your debridement, your workup, and making sure that the disease is adequately treated before the reconstruction. Certainly, these authors are experts on small perforators, perforator anastomoses, superficial harvest of these fascial flaps. So certainly they're the experts, but for people who may not have the breadth of experience that they do, muscle flaps can also be a reliable alternative. Jordan, what did you think of this article?
I thought it was really an interesting article, and I enjoyed reading it. Dr. Hong and his team are obviously really masters at this and kind of should be commended. They're tackling really tough problems and doing really elegant surgery and getting great results. It's funny because I was reading it and it kind of taken back to earlier in the year when I was at Bellevue and doing our indications conference. Like Monday morning, we would have all these lower extremity trauma patients that needed free flaps, and half of the attendings in the room would say, you got to do a muscle flap where you're thinking these are traumatic, dirty wounds, and cover it with some muscle, and you'll get better contour anyway. And then the other half of the room saying, no, you got to do a perforator flap. It'll be easier. You're gonna have to re-elevate, put IM nails in, and you got to do a perforator flap. But I think like everyone's saying, it really comes down to what you're comfortable with and gives you the best results. And you can probably get good results with both as long as you're facile with it. I also think, and Dr. Henry in his discussion mentions it's a caveat, not an insignificant portion of these patients really did get muscle flaps because they're getting the vastus on a separate pedicle, albeit, but there is being some muscle put in there to fill out the bulk, which is a really important point that the authors are making. Dr. Gangopadhyay, I'd be interested to hear if you could walk us through briefly kind of what your approach is to bony defects in these kind of patients. They discuss iliac crest grafting or vascularized bone flaps. How do you kind of approach this and assess if a patient is ready for bone reconstruction?
Certainly, I think that's an excellent point that I wish the authors had spent a little bit more time on. So in my experience, the most important bone really in the lower leg, of course, is your tibia. So potentially if you're dealing with an open fracture just involving the fibula, I think there's much less indication to go back and re-elevate your flap and then put in a bone graft. Certainly when I'm thinking of these bony fractures and then kind of long-term osteomyelitis, I tend to delay the bone reconstruction. So I agree with the authors that in general, you want to get an adequate sense of debridement, make sure that your cultures are negative and that all signs of osteomyelitis are gone, and then do an adequate soft tissue reconstruction before you go back in and potentially do a bone reconstruction. And so anything you can do to decrease the inflammation and optimize the wound healing potential in that area is important. But if you do have to go back, it typically would be for a larger tibial defect. And if they're kind of small cortical breaks or unicortical breaks, and they are not causing issues with weight bearing or function of the leg, I don't necessarily think you always have to go back and add in bone graft. Certainly for a larger defect that would potentially compromise the weight-bearing function of the leg. One option is to perform either a pedicled fibula flap from the ipsilateral leg, or potentially go back and do a second free flap, taking a free fibula from the contralateral leg. For smaller defects, in this situation, I'm thinking defects that are less than 4 centimeters or so, I think taking just iliac crest cancellous bone, similar to what we would do for an alveolar bone graft patient, is a reasonable option. And I will often mix in some BMP into that as well, because even in an adult, you usually can't get enough cancellous bone to completely fill that defect. But I certainly agree with staging the reconstruction. I tend to wait a little bit longer for the bone reconstruction. So I think in the article, they mentioned anywhere from 4 to 8 weeks. And I usually tend to wait anywhere from 3 to 6 months to go back. And a lot of that is how mature I feel the flap is and how reliable some of that collateral circulation will be when I re-elevate it.
Thank you for going through that with us. I think that's very, very helpful. Chad, what were your thoughts on this paper?
I agree with everything that's been said. I mean, Dr. Hong is an absolute beast of microsurgery. And I think that what he's able to do with perforator flaps and super thin perforator flaps, working in the zone of injury with perforator to perforator anastomoses, it's just amazing. And I mean, I think these results are incredible, especially with a problem so difficult as chronic osteomyelitis in these comorbid trauma patients. I think this article gives us kind of a gold standard of how well chronic osteomyelitis can be treated in a very difficult patient population with a very, very low amputation rate overall and a high success rate of remission of osteomyelitis. So I think this paper really sets the standard of what can be done if you're truly a master of microsurgery and what you can do if you're able to do these extremely difficult micro cases. So I was really encouraged by this paper, and I think it's a great paper overall. So as I alluded to, Dr. Gangopadhyay, chronic osteomyelitis is a bad problem. And these are patients, just like in this study, that are comorbid, they're smokers, they've got diabetes, they've had polytrauma, and they've got vascular issues. And so how do you approach a patient whenever they have chronic osteomyelitis and they're seeing you for their initial treatment? How do you counsel them?
I think that's a very good question, Chad. So I really think that setting yourself up for surgical success starts in the preoperative consultation. And unfortunately, sometimes you're not seeing these patients in the clinic where you can spend a long time with them. Sometimes you're being called maybe 1 or 2 days after the trauma, or when they've been readmitted to the hospital with kind of a limb-threatening infection. And so I think your approach has to be measured. So one of the most important things is making sure that you're giving them a unified approach with your orthopedic surgeon as well as with the infectious disease specialists. And other specialists that can often be helpful for you are working with your vascular surgeon and then often an endocrinologist or a general medicine practitioner to do everything you can to optimize these patients, whether it's controlling their blood sugar, trying to decrease their exposure to nicotine, trying to improve their vascularity, which the authors mentioned briefly at the end. In some of these patients, I probably would recommend getting a bypass or at least some form of arteriogram and stenting to help improve the distal blood supply. And then controlling their blood sugar, certainly, and making sure their protein levels are optimized. I also think it's really important to talk to them about the importance of getting a good diagnosis on the culture and the fact that the reconstruction itself will be staged, so that one surgery may not be enough to fix their problem, and that this is going to be a kind of a long-term thing that you're going to be dealing with and seeing them over the course potentially of a year. So when I'm talking to them about the other factors that I need to optimize, I'm also trying to figure out what their social situation is. Because if they're not able to comply with postoperative restrictions, or they potentially don't have access to affording the right medication or making it to their follow-up appointments or getting to therapy, you're already setting yourself up for failure. So I think all of those things need to be taken into consideration at the preoperative appointment. And then, of course, I also counsel them that there is still always a future risk that the osteomyelitis may come back. And I love that the paper references it as an osteomyelitis that's gone into remission rather than something that they've eradicated, and that potentially amputation may still be on the table even if you've done everything you can to optimize the patients. But I really think that multidisciplinary approach with orthopedic surgery, plastic surgery, infectious disease, vascular surgery, and then potentially endocrinology, internal medicine, and social work and your physical and occupational therapy services is critical.
Great. I think those are great points, and that'll be really helpful next time we're counseling one of these difficult patients.
I think that was a really awesome discussion of this excellent article. I think that's, as everybody said, it's a hard problem to treat. These guys are definitely the masters in terms of doing these reconstructions. I'd like to reiterate, I thought it was a great description of their overall protocol. But I think with that, we'll end our discussion of this article. Remember, everyone, to tune into the other 2 articles we'll be discussing on this month's podcast, as well as all our previous and future podcasts broadcasted every month. Also, don't forget to participate in our monthly hashtag PRS Journal Club on Twitter, where we'll be able to interact directly with this month's selected articles' authors. And once again, thank you very much, Dr. Gangopadhyay, for joining us today.
You're so welcome. Thanks for having me.